The following podcast is part of a certified educational activity titled Breaking Down the Evidence in Bladder Cancer, Expert Perspectives and Practical Strategies on Immune, Targeted, and Antibody-Based Therapies, featuring Petros Grivas, MD, PhD, from the Fred Hutchinson Cancer Research Center in Seattle, Shilpa Gupta, MD, from the Taussig Cancer Institute Cleveland Clinic in Cleveland, and Gary D. Steinberg, MD, from NYU Langone Health in New York. Access the entire activity and complete the post-test at peerview.com/RPD860. Downloadable slides and practice aids are also available.
Thanks everybody for joining this evening. We're very excited to be with you, and I'm very excited myself here to be surrounded and learn by Dr. Shilpa Gupta and Dr. Guy Steinberg, who are going to join me today. So as we start here the program, I just want to set the stage by saying we have come a long way in urothelial carcinoma and bladder cancer and upper tract disease, but we still have many shortcomings, right? A lot of challenges that we have to come up with. For example, only 1/3 of patients with non-muscle-invasive disease are given intravesical BCG treatment, and many patients who receive induction therapy may not be able to get maintenance, especially in the context of significant national BCG shortage in the United States right now that impact access to therapy. In muscle-invasive disease, many patients do not undergo curative intent therapy, and that's a big issue, right? Patients who undergo radical cystectomy may not be offered standard of care, neoadjuvant cisplatin-based chemotherapy, or concurrent chemoradiation or bladder preservation, and patients who get a radical surgery for muscle-invasive disease may have impaired quality of life and impaired patient-reported outcomes. In metastatic disease, we have accesses with healthcare disparities, access to therapy issues, and we have a very low rate of completion of clinical trial enrollment, and many patients, more than half, may not have access to first-line therapy. And many patients who progressed on first or second-line therapy may not receive subsequent therapies. We published recently that about only 20% of patients make it to second line. That's a big issue, right? We have to improve upon that. And post-immunotherapy therapies are now available, antibody-drug conjugates, FGFR inhibitors, but some significant proportion of patients may not receive those important therapies. So today we have a very exciting agenda and then excellent speakers. We're going to discuss the data in early disease, specifically on immunotherapy, and Dr. Steinberg will take the lead in that. We're going to have Dr. Gupta discuss updates in first-line management of advanced urothelial cancer, and I will finish off the evening by defining therapeutic roles of antibody-drug conjugates and FGFR inhibitors. So without further delay, we'll give the microphone to our exceptional and spectacular Dr. Gary Steinberg. He's a professor in the Department of Urology in NYU, New York. Gary, the stage is yours.
Thank you very much. It's a pleasure to be here. It's a pleasure to be not quarantined and to be in a live meeting. The non-muscle invasive bladder cancer space has changed drastically over the last number of years, and as we know, the vast majority of patients with bladder cancer present initially with non-muscle invasive disease. This is a trial, Keynote 676. It's with Pembrolizumab Plus Bcg. This is a trial that I helped put together, and I'm on the steering committee. But essentially, we're looking at patients with high-risk non-muscle invasive bladder cancer that have received at least one course of BCG, one induction course of BCG. Again, we were trying to look at a real-world population because we know, as Petros just said, a lot of patients do not receive adequate BCG, and they do not receive maintenance BCG on any schedule. So this is a randomized trial looking at pembrolizumab and BCG versus BCG alone. They've added an additional cohort, which is now open, and this additional cohort is for patients with high-risk non-muscle invasive bladder cancer who are BCG naive, and they'll randomize to BCG plus pembro versus BCG. The evidence continues to support immune checkpoint inhibitors in high-grade non-muscle invasive bladder cancer. Keynote 57 was FDA approved. Pembrolizumab was FDA approved for high-risk BCG unresponsive carcinoma in situ. There is still a cohort B ongoing, which is for papillary high-grade disease, to be randomized, to receive open-label pembrolizumab. But the important part of this study is that this created a new baseline. I personally believe that the treatments for non-muscle invasive bladder cancer in the future will be combination therapy. This is our new baseline. This was FDA approved. And we see that at the complete response rate at 3 months is around 40%. The duration of the response of patients who are disease-free 12 months beyond their complete response is about 45 to 50% of those patients. Overall, 19 patients, or 19%, have a durable complete response at 15 months or greater. And with the update, we see that of the 39 responders, at 18 months, we still see 13 of 39 who continue to be disease-free, and even patients who are durable disease-free beyond 18 months. So this is our new baseline. And again, the outcome from this study, this was a well-done study, but it's consistent with what we see with checkpoint inhibitors for all cancers. And then to support that, we have the SWOG S1605, which the headline was that it was a negative trial. But actually, this trial supported what we saw with the pembrolizumab trial, in that when you look at an unplanned secondary endpoint, the complete response rate at 3 months was 42%, almost identical to the pembro. The complete response from the primary complete response at 6 months in this trial was 27%. And then when we look at these patients, the 12-month complete response rate, again, almost identical to pembro. So I think that we can say that as a class, the checkpoint inhibitors will be incredibly effective in about 20% of patients. And again, we need to look at biomarkers to see who will best respond to these treatments. Now moving gears a little bit into the muscle-invasive space, looking at bladder preservation. This was a trial, and this was a multi-center trial, although Arjun Balar at NYU was the primary investigator. And this looked at patients with muscle-invasive bladder cancer. They received pembrolizumab up front. They had a maximal TURBT. Again, part of that is to create an additional immune cell death and to help make the radiation more effective. They received radiation, gemcitabine, and pembrolizumab. They received some adjuvant pembrolizumab post-treatment. This was a well-tolerated trial at the median follow-up of 14.6 months for the efficacy cohort. The primary endpoint of estimated 1-year bladder intact disease-free survival was 88%. The complete response rate was 77% at 12 weeks post-radiation therapy. This is clearly a trial that again is trying to define what is possible. We're still not clear if there's any added benefit from the pembrolizumab, and there's now an ongoing trial comparing a randomized trial looking at with or without pembrolizumab in bladder preservation. Updates in bladder preservation, neoadjuvant trials in patients with DDR mutations. We had some very nice talks this afternoon about these topics, but there are a number of trials looking at combinations of checkpoint inhibitors, chemotherapy, and so forth to see if we can preserve patients' bladders without a cystectomy. So there's the RETAIN trial and the Alliance trial. Essentially, you have a TURBT, the tumors are sequenced, you look for DNA repair, DNA damage repair mutations, and that if you have DDR mutations and you have a complete clinical response by CT, MR, and biopsies and so forth, you can be placed on active surveillance. If you have a non-muscle invasive disease despite chemotherapy, you can receive cystectomy or you can receive intravesical therapy or radiation and so forth. And then this is another trial that we have some updates. We have some data, 76 patients. There were 31 patients had a clinical CR, 33 patients did not have a clinical CR. In the patients with the clinical CR, 30 patients did not undergo cystectomy, 1 did. And as you can see from the swimmer's plot here, that we have a lot of very interesting data. This will need to be followed up longer, but we do have a number of patients with no evidence of disease, and there are some patients, however, who did recur. I don't believe there are any patients who developed metastatic disease. Another area of importance in non-muscle invasive bladder cancer, but all bladder cancer, is targeted therapy, precision therapy. We know that there are a fair number of FGFR mutations and alterations, especially in non-muscle invasive bladder cancer, specifically low-grade non-muscle invasive bladder cancer, but we do see about 30 to 35% of patients with papillary high-grade disease will have FGFR3 alterations. We also see in the muscle-invasive space about 15 to 20%, and that in the metastatic disease, again, about 15 to 20%. Carcinoma in situ, which is one of the diseases that we study many times in these clinical trials, it's unclear what the FGFR3 alteration rate is. I think it's probably less than 5%. And this is a trial. I'm the study PI and the steering committee chairman of this trial. We're taking patients who have received intravesical BCG. Ideally, they'll be BCG unresponsive. However, we're looking also at a new definition of patients who are BCG experienced or BCG exposed and with papillary disease. And they've got FGFR3 alterations, and they're randomized to erdafitinib, which is an oral agent, versus either mitomycin C or gemcitabine. Excuse me. We also are including heated mitomycin C. But we're looking at the outcomes of this trial. We're also looking at a group that has CIS with or without papillary disease, and we're also looking at a marker lesion trial. One of the things that we noticed in this trial was the fair amount of toxicity in the patients and kind of the unwillingness to continue on the trial when we were starting with the 8 milligrams and titrating it up to 9 milligrams. So we've dropped the dose to 6 milligrams and even titrating it down to as low as 4 milligrams. There's data to suggest that that is an adequate dose. Again, we're treating non-muscle invasive bladder cancer and not metastatic disease, and we're seeing a lot more patient acceptance of the treatment. And one of the problems with intravesical chemotherapy in the past has been that the pharmacokinetics of the treatment was that patients received the treatment, they urinated it out, and it was unclear how much of that medication was actually absorbed or became active. The Terrace pretzel allows you to have slow delivery of drugs over a week, 2 weeks, 3 weeks, any way that you want to design it. And we've got a number of trials using the Terrace pretzel with or without citrilimab, which is a PD-1 inhibitor. And so you've got a trial for non-muscle invasive BCG unresponsive and randomizing the Terrace pretzel with gemcitabine and citrilimab versus the pretzel alone versus citrilimab alone. And then we've got a patient population with muscle invasive bladder cancer unfit for cystectomy who are randomized to chemoradiation or the pretzel plus citrilimab. There are a number of trials looking at FGFR alterations in an adjuvant setting. As we know, we've got some adjuvant IO that's been FDA approved. This is using patients who have FGFR3 alterations, and there's 2 trials, one with QED, the ingratinib trial, and then the other with pemigatinib. Both of these are FGFR alteration drugs. And you've got upper tract disease and or bladder, and patients receive this as an adjuvant therapy. Something that I've discussed and some of the people talk about is it okay to have placebo as your control arm? Because we do have some data now about adjuvant therapy in high-risk disease and with checkpoint inhibitors. I think that when you look at FGFR3 alterations, maybe it's in theory those patients do not respond to checkpoint inhibitors theoretically, although there's data to suggest that they may, and so it's a question to continue to discuss. Neoadjuvant chemotherapy, it's become the standard of care that patients receive cisplatin-based chemotherapy before radical cystectomy or radiation. But again, we know that cisplatin-based chemotherapy is effective, but just not effective in enough patients. And so that overall, while you do see an overall median survival benefit, it probably only truly benefits 30+% of patients. So that we need to move beyond that. And we're doing that with a number of trials looking at combinations of checkpoint inhibitors and chemotherapy or novel agents, including, BMS has got a nivolumab plus IDO inhibitor, lorlatinib. There's also Pembro plus EV, enfortumab vedotin. We've got Nivo plus pegladicin it's an IL-2 drug. I can never pronounce that drug anyway. And then we've got a number of trials with with Tremi and Durvalumab and so forth. So the future is bright with a lot of combination therapy trials in the neoadjuvant space, and certainly this will also contribute to potential bladder preservation. Looking at disease-free survival and overall survival as endpoints in ongoing adjuvant muscle-invasive bladder cancer trials with PD-L1, PD-1 inhibitors. We know IMvigor010 was a negative trial. We know that Checkmate 274 was a positive trial, and we're still waiting for Ambassador. Although the Ambassador trial closed to accrual, they were close to hitting their goal, but they closed to accrual once nivolumab received the FDA approval in the adjuvant space. With IMvigor010, as spoken about earlier this morning, one of the key findings were that if you had circulating tumor DNA, so that if you had evidence of residual disease, getting atezolizumab was beneficial. When you looked at all comers, there was no added benefit, but if you looked at only the patients with disease, and this is consistent with the Pembro trial in multiple myeloma in patients that had disease, did benefit from adjuvant pembrolizumab. And then just looking at the disease-free survival, we see that with nivolumab, there was all comers, whether you were PD-L1 high or low. All comers had a significant improvement in disease-free survival, and especially in patients who were PD-L1 high. As with all therapies, there is a benefit, but there's also a potential downside, and so that with adjuvant therapy, checkpoint inhibitors, we know that the class effect, we're going to see some IRAEs approaching 10 to 12% or so, and that the most common are skin, and there's diarrhea, colitis, pneumonitis, thyroid conditions, and so forth. And from there, I'm going to turn back to Petros.
Excellent job, Gary. Thank you. You did that in a very efficient way. It's like I leave us time for question. Great data, and thank you for presenting those. So let's go to that case so we can learn together. So this is a 58-year-old gentleman who presented with hematuria, the most common presentation of bladder cancer. And just here to put the plug for early diagnosis and the need for early workup, for both men and women with hematuria. That's an important point to give to the community out there. So this man had the proper workup with cystoscopy, TURBT, and CAT scan, chest abdomen pelvis with IV contrast. He was found to have a bladder tumor, and the TURBT confirmed muscle-invasive disease, muscularis propria invasion. This patient was a good candidate for cisplatin-based chemotherapy, good performance status, good kidney function, no significant hearing loss or neuropathy, and no significant heart failure. So was treated with 4 cycles of neoadjuvant Gemcis, and then proceeded with radical cystectomy, so prostatectomy to be more specific, and pelvic lymph node dissection. Pathology revealed a YPT3N1, so despite the appropriate use of cisplatin-based chemotherapy, in this case with level 1 evidence, this patient seems to have platinum refractory disease biology based on the T3N1 status at the time of surgery. So let me ask here, Gary and Silpa, this obviously was a standard approach here. What are your thoughts when you see patients like this, with a really advanced stage, despite the proper neoadjuvant chemo? Would that be a patient for a clinical trial, adjuvantly, adjuvant nivolumab? Gary, we'll start with you.
So this is a very, very common scenario. And again, cisplatin neoadjuvant chemotherapy is good, but clearly there's a lot of room for improvement. And that we woefully clinically understage our patients with bladder cancer. And so this is actually a very, very common finding. Historically, if you look at the data, this patient will have a very poor outcome with recurrence of metastatic disease. And many times when you would try to put this patient on a adjuvant therapy trial, by the time they recovered from their cystectomy and that you're restaging them 2 to 3 months after their surgery, all too often they do have metastatic disease at the time that you're restaging them. But nonetheless, I think that we clearly have a standard of care now with Checkmate 274 nivolumab, and I would try to get those patients on that as soon as possible. I don't believe that we're going to make any headway with additional chemotherapy. And then last but not least, all of these patients should be sequenced if they haven't been sequenced already.
Great points. Thank God. I totally agree with you 100%. Silpa, any additional comments?
No, I totally echo what Dr. Steinberg just said, would use adjuvant nivolumab in this patient.
Sounds great. So moving forward here, Dr. Silpa Gupta is going to discuss some exciting data in the frontline metastatic disease. Silpa, I have a question for you, though, before you give your talk. Actually, for both of you. It's an interesting question in the iPad. If you have a patient with upper tract disease, right, not cisplatin fit patient, would you go for adjuvant carbo-gem? Would you go for adjuvant nivo or a clinical trial? Silpa, I will ask you first and then Gary.
Yeah, as you know, Petros, in the upper tract disease data from POUT trial showed advantage for cisplatin-based adjuvant therapy, but not for carboplatin-based. And we have a prospective clinical trial evaluating the utility of FGFR inhibitor in those with FGFR altered or mutated tumors. So I would prefer to enroll on that trial since using gem-carbo would really not be that effective. And nivolumab is approved in those patients as well. So if trial is not an option, adjuvant nivolumab would be my choice, although in the subgroup analysis, those patients did not benefit that much in the CheckMate 274, albeit the numbers were small.
Thanks, Silpa. Gary?
So again, as much as we woefully are inadequate in our clinical staging of bladder cancer, we're even more so in upper tract disease. And all too often, if you can see something radiographically, while we think that it may be high-grade non-invasive, many times it's not only T2, it's T3 and beyond. Sometimes there are some positive nodes. So I think it's critically important that we try to stage these patients and think about cisplatin-based chemotherapy up front. Having said that, bladder cancer and upper tract urothelial cancer are not the same. They're cousins, but they're not identical twins. And I think that it does call for sequencing these tumors, and potentially, if they are FGFR altered, I would favor a adjuvant trial with an FGFR3 inhibitor.
Thanks, Gary. No, great points. I agree. I think there is probably equipoise there for an adjuvant trial if it's available based on this context that you just answered. And the options for those patients will be carbo-gem, uncertain benefit with a POUT trial in this subset analysis, the question about nivo in that subset of patients, and of course, the question of trial. And a very quick answer here, someone asked, did patients on the CheckMate 274 trial get nivolumab if they never received neoadjuvant chemo? And the answer is these patients were allowed if they were not fit for cisplatin, and they are not fit for cisplatin for the adjuvant setting, they were allowed to get adjuvant therapy on the CheckMate 274 trial. So I think it's cisplatin eligibility fitness is important in the context of adjuvant nivolumab, I think, based on the CheckMate 274 trial that Gary presented. Silpa, now we'll let you guide us through the very, very exciting data, and thank you for being here.
Thank you, Petros. I'm really excited to talk about updates in the first-line management of advanced urothelial cancer. So the current state of immunotherapy in metastatic urothelial cancer has really evolved over the last few years. For newly diagnosed patients who are eligible to receive cisplatin, the current Category 1 evidence is for gemcitabine and cisplatin to be used in these patients, followed by avelumab maintenance based on the Javelin Bladder 100 trial. And if patients get any cisplatin-based regimen like dose-dense MVAC with growth factor support, that's reasonable as well. Both are Category 1 recommendations as long as patients receive avelumab if they have not progressed. For newly diagnosed patients who are not cisplatin eligible, and we see this to be around 50% of our patients, gemcitabine and carboplatin followed by avelumab maintenance is the Category 1 recommendation. And for patients who are not eligible to receive any platinums, atezolizumab and pembrolizumab are reasonable single-agent options. And for patients who've had prior chemotherapy or relapse within 1 year of perioperative or adjuvant cisplatin, pembrolizumab is the Category 1 recommendation, although nivolumab and avelumab are also approved, but they don't have Category 1 recommendation. Therapy has really evolved in locally advanced and metastatic urothelial cancer after a long void of 4 decades when we did not have any novel therapies. In 2016, we saw the first immunotherapy approved, and since then there's been explosive growth in the approvals of immunotherapy and novel targeted therapies. We had 5 checkpoint inhibitors approved in 2017. In 2019, erdafitinib, which is an FGFR3 inhibitor, was approved, and the antibody drug conjugate enfortumab vedotin was approved same year. And in 2021, another antibody drug conjugate, sacituzumab govitecan, was approved. And last year, we saw the approval of avelumab maintenance. Want to highlight here that atezolizumab and nivolumab were voluntarily withdrawn for second-line indication due to lack of benefit in confirmatory trials. And pembrolizumab and atezolizumab are now only recommended for patients who are ineligible for platinums, although atezolizumab could still be considered for high PD-L1 patients, although not preferable. There are multiple trials that have looked at incorporating immunotherapy into frontline urothelial cancer, and I'll quickly highlight some of the trials that have resulted. The IMvigor 130 study, which enrolled 1,200 patients, compared atezolizumab and chemotherapy combination to single-agent atezolizumab or placebo and platinum-based chemotherapy. We saw a modest progression-free survival, but no OS survival so far, so we're still waiting for the final results. Keynote 361 trial was a similar patient population looking at pembrolizumab and platinums versus pembrolizumab or just platinums. Unfortunately, this was a negative trial, did not meet the overall survival or progression-free survival endpoints. Danube was a trial looking at just immunotherapy doublets, durvalumab and tremelimumab compared to durvalumab versus standard of care chemotherapy, and this trial was also reported to be negative. So far we've seen that chemotherapy was not inferior to any of the combination approaches, unlike lung cancer. And the CheckMate 901 trial, which is comparing nivolumab and ipilimumab to nivolumab plus Gemcis or carboplatin versus standard of care chemo, is still ongoing, and we should see the results in the coming months. Now, despite successes in other tumor types with chemoimmunotherapy combinations, in urothelial cancer, we have not yet shown that in the phase 3 trials. So there's a question of sequencing approach. Is lead-in chemotherapy followed by sequencing of immunotherapy a better approach? And this is the pivotal trial, the Javelin Bladder 100 trial, which used the switch maintenance approach after frontline platinum-based chemotherapy. So patients who received frontline platinums and did not progress after that were randomized to avelumab versus best supportive care, and primary endpoint was overall survival. And this trial showed a 7-month improvement in overall survival in all comers with avelumab compared to best supportive care, and the overall survival in the PD-L1 positive subgroup was not reached. So this is the current standard of care. And across the subgroups, the benefit was observed regardless of PD-L1 status and regardless of the choice of chemotherapy and the number of chemotherapy cycles, whether 4 or 6. And this was FDA approved last year to treat patients with locally advanced or metastatic urothelial cancer who do not progress after frontline platinums. So what immunotherapy options are available in frontline setting? As mentioned before, first-line platinum-based chemotherapy is the preferred option for patients if they are eligible. A switch maintenance strategy enables more patients to receive an immune checkpoint inhibitor as a part of frontline therapy versus reserving that option for second-line therapy, considering there's a significant attrition and lack of reliable biomarker to progression. Treatment-free interval between the end of chemotherapy and start of avelumab in the Javelin Bladder 100 trial was 4 to 10 weeks, and overall survival and progression-free survival was benefit was observed regardless of multiple factors. And despite this, there's a 15 to 20% patients who will ultimately progress despite these approaches. And survival rates are low for patients with metastatic disease who progress after platinum-based chemotherapy. Pembrolizumab monotherapy is approved and has a level 1 evidence in the second-line setting based on the Keynote 045 study, which showed significantly improved overall survival compared to standard of care chemotherapy. Nivolumab and avelumab are approved. However, they have not shown benefit in phase 3 settings. And this is the pivotal trial for pembrolizumab approval in second-line metastatic urothelial cancer. As you can see here, the response rates were 22% with pembrolizumab compared to only 11% with chemotherapy. Complete response rates were 27% compared to 8% with chemo. And the tolerability was, of course, much better than the chemotherapy. Now, coming to the topic of immune-related adverse events, we know that immunotherapy in general is extremely well tolerated compared to chemotherapy. However, it can have a unique set of side effects because of the mechanism of action. And pretty much any organ system can be affected by immunotherapy. The most commonly occurring side effects are gastrointestinal, like diarrhea, enterocolitis, transaminitis, hepatitis, pneumonitis, and skin side effects like rash, pruritus, blisters, and a wide variety of endocrine abnormalities, which can sometimes be very subtle to detect but easy to manage. And supporting effective communication amongst multidisciplinary healthcare teams is really crucial to managing immune-related adverse events. And we have to be cognizant that immune-related AEs can occur any time following initiation. Even when patients stop immunotherapy, months later, they could present with an immune-related adverse event. And we have to always keep it at the back of our minds that it could be from immunotherapy. Always do a multidisciplinary referral approach. Even though all oncologists are really good at managing side effects, it's really important to involve the specialties like gastroenterology, dermatology, endocrinology when appropriate. So some of the recommended strategies for managing immune-related adverse events have now been widely available via ASCO, NCCN, SITC, and ESMO guidelines. So if anything is very mild or grade 1, we can consider immunotherapy or temporarily hold it. There is really no dose reduction of immunotherapy. And we treat the patient symptomatically. If there's a rash, we could give topical steroids. No definite need for systemic steroids at that time. For grade 2, which is more symptomatic, we should withhold immunotherapy and initiate systemic corticosteroids at a dose of 0.5 to 1 milligram equivalent of prednisone per kilogram. Taper steroids over 1 month or as appropriate depending on clinical symptoms and resolution. And if toxicity resolves to grade 1 or lower, we could re-challenge with immunotherapy. And for grade 3 and 4, which are really very severe and may require hospitalization, we have to discontinue immunotherapy, promptly hospitalize the patient, not to worry about high-dose corticosteroids impacting efficacy because they don't. And the treatment of dose for prednisone in such cases is 1 to 2 mg per kilogram or equivalent, and taper it very slowly. And we've seen from a variety of diseases that patients who develop significant immune-related adverse events are paradoxically the better responders. So we really have to be very vigilant to treat these patients instead of worrying about affecting the immunotherapy efficacy. And there's a lot of other immunosuppressive treatments available like anti-TNF therapy, infliximab, mycophenolate, budesonide, and involving the appropriate subspecialties is the best thing to do. So for practical tips for mitigating and managing immune-related adverse events are pretty simple pre-medication with antihistamine and acetaminophen for patients who've had infusion reactions in the past. Avelumab is notorious for infusion-related reactions, so one could also do it preemptively. Monitor patients closely with each visit. Even if the patient is doing well, immune-related adverse events can happen anytime. Monitor their labs frequently. Query patients about symptoms because patients do tend to underreport side effects from immunotherapy. And be vigilant for signs and symptoms of pneumonitis or colitis. And consult the published guidelines. I'll hand over to Dr. Grievous to take it from here.
Thank you so much, Dr. Gupta. Fantastic efficiency. And Dr. Gupta is an associate professor in Cleveland Clinic and has done tremendous work in the field. And also, Shilpa, I think that one of the first immunotherapy-related adverse event tumor boards was in Cleveland Clinic, where you are, and this is a great resource.
Thanks to you, Petros.
It's a great teamwork, and as Dr. Gupta mentioned, I think involving the specialist early on is very important, so absolutely great point there. I think that's an interesting case. An 81-year-old gentleman with chronic kidney disease, creatinine clearance below 30, that's pretty low, ECOG PS of 2, PD-L1 low based on the CPS score, only 1, current smoker despite canceling against smoking, type 2 diabetes mellitus, and no history of autoimmune disease, no steroids, present with hematuria, found to have bladder tumor, TURBT showed urothelial carcinoma. This was a T3 disease based on imaging and a TUR evaluation, and sadly there was evidence of metastatic disease at the time of diagnosis, so retroperitoneal lymphadenopathy and pelvic lymphadenopathy at the same time. Dr. Gupta, we'll start with you. I know you led a very important effort in 2019 trying to define patients who are not eligible for platinum, cis and carboplatin. Based on that work you led, any comments on this case? How would you approach this patient?
I think given that this patient has a creatinine clearance of less than 30, 80-year-old man with peak ECOG performance status of 2, would be hesitant to use carboplatin really in this patient. And this is the patient we could define truly as a platinum ineligible patient, and single agent use of pembrolizumab or atezolizumab would be reasonable.
Dr. Steinberg, any comments?
Well, I think Dr. Gupta picked up on the key points. 81 years old, multiple medical problems, poor performance status, chronic renal insufficiency, diabetes, current smoker. I would be concerned about carbo as well, and I think that you don't lose anything by starting him on Pembro.
I think I agree with both Dr. Gupta and Dr. Steinberg here. One of the criteria that came up from this consensus survey that Dr. Gupta led was these patients with poor performance status ECOG PS of 2 and creatinine clearance below 30. These are challenging situations, so I think about checkpoint inhibitor is a very reasonable option, and pembrolizumab or atezolizumab are FDA-approved options in that setting. And of course, doing clinical trials in this population is hard. It is an important point that if we can get more options for those patients, will be great. I have a question here, actually, for Dr. Steinberg. It's from the previous session, but I think we can tackle it. Where do you see the impact of intravesical gemcitabine, with or without immunotherapy? That's an interesting question because gemcitabine may impact myeloid-derived suppressor cells, MDSCs, can suppress MDSCs and be immunostimulatory. Any comments on that question?
Well, I think that the key is not only the drug but the delivery, and so that there is data to suggest that the slow, continuous delivery of gemcitabine will suppress T regulatory cells in MDSCs. In addition, you may be creating, our golden ring, which is immune cell death, and so that you may have kind of three-pronged immunologic effect as well as cytotoxic effect on the urothelial cancer. And then, if you're truly turning on immune cell death, you may need a checkpoint inhibitor. And so I think that the trials that are designed are with the gemcitabine alone, or gemcitabine plus citrilimab, or citrilimab alone. And I think it's a nice design to answer a number of questions. Is the gemcitabine solely cytotoxic? It's an analog, nucleoside analog, or is it also immunologically active? And I think that if it is, then I think that should get some synergy.
That's a great point. And actually, this question brings to my mind, Dr. Steinberg, Dr. Gupta, we have a neoadjuvant upper tract trial that we just designed with Dr. Hoffman-Sensitz from Johns Hopkins in the ECOG-ACRIN group, ECOG-ACRIN 8192, and has a cisplatin-eligible cohort with dose Densenvac plus minus durvalumab, and cisplatin-ineligible population, about 30 patients will get durvalumab plus gemcitabine as a neoadjuvant therapy before radical nephroureterectomy. So we'll find out there if there is any value. So thank you for the comment. So I'll take it on here to discuss some really, really exciting updates in metastatic urothelial carcinoma Usually, platinum-based chemotherapy, as Dr. Gupta mentioned, is the initial treatment, and of course, checkpoint inhibition, as he talked about, has a significant role. But what about antibody-drug conjugates and FGF receptor inhibitors? I think these are very, very exciting agents and established role in this disease. I think it's important to make the point here that both urologic oncologists and medical oncologists have very important roles in co-managing and educating the patients on the importance of genomic testing. Dr. Steinberg mentioned before that in patients who have node-positive disease after a neoadjuvant chemo and cystectomy, in support to get this next-generation sequencing, NGS, done, to look for potential targets for clinical trials, but also to inform potential therapy decisions in the metastatic disease setting. And one of those targets is FGFR, specifically FGFR2 and FGFR3, activating mutation and fusion, which is a target for erdafitinib that we'll talk in a second. And there are two ways to check for those biomarkers, either RT-PCR QIAGEN test, which is a companion assay that was approved by the FDA along with erdafitinib, and also more comprehensive NGS panels. And Dr. Gupta, any preference on how you approach genomic testing, and when do you test?
Yeah, I think the sooner we test, the better. In my practice, I tend to test them when patients have metastatic disease, just to keep an option open for later on. As far as the platform used, we typically use the available NGS and not necessarily the QIAGEN. But it's an option for sure.
Dr. Steinberg, would you do the same?
Well, I think in the non-muscle invasive bladder cancer patients, I think probably I would use the companion diagnostic from Janssen. But I think that if I had my druthers, I would probably want to get sequencing, either Foundation One or interinstitutional sequencing.
I agree with you. I think in metastatic disease, I do the next generation sequencing to get a broader panel to look for other targets too that may inform subsequent clinical trials, including the FGFR2 and 3 alterations. And I do it at the time of diagnosis of metastatic disease, unless I do it earlier to screen for an adjuvant clinical trial that Dr. Steinberg mentioned before. So there is a plethora, Greek word, right, there's a good number of FGF receptor inhibitors that have been tested in metastatic urothelial cancer. And you see here response rates across different trials. I always caution, the trainees, don't compare across different trials. There are different selection confounding factors. But as you see here, there's definitely data with activity among different FGF receptor inhibitors, and we have seen a similar story with checkpoint inhibitors, that we have activity across different agents, showing that the class of these agents are active in this disease. Specifically, based on the BLC 2001 trial, we have an accelerated approval of erdafitinib for patients with metastatic urothelial cancer with FGFR2 or FGFR3 activating mutation or fusion after progression of platinum-based chemotherapy. So platinum refractory disease, and just to make the point here, is not FGFR1, it's only FGFR2 and 3, and it's not amplification. It's only activating mutation or fusion. But you see activity across different agents here, and infigratinib is being tested in the adjuvant setting in the PROOF 302 trial that Dr. Steinberg presented before. So what is the data behind the accelerated approval of erdafitinib in platinum refractory disease? This was a BLC 2001 trial. This was published in the New England Journal of Medicine by Dr. Loriot and colleagues 2 years ago. These are patients with metastatic disease. They are platinum refractory, so they have platinum-based chemotherapy, most of them, and prior immunotherapy was permitted. The dose that went forward was the 8 milligrams once a day until progression or unacceptable toxicity. So the third box there on the right, 8 milligrams once a day. That's the starting dose. As you see in the next slide, in this Swimmer's plot, you have an overall response rate of 40% in this platinum refractory disease. Again, these are patients selected based on the FGFR2 or 3 activating mutation or fusion. Most of them were partial responses, the vast majority. And among the 22 patients, small sample size, who have prior checkpoint inhibition, the confirmed response rate with erdafitinib was 59%, so very promising number there. Obviously, this was a single arm, not randomized study, but you see some patients have durable response. And as you see here, based on duration of response and the promising signal of survival in this single arm study, showing that erdafitinib has activity, this led to the accelerated approval of this agent for patients with those biomarker positive disease. And the activity of erdafitinib was regardless of the alteration type, mutation or fusion, tumor location, upper tract or lower tract, presence or absence of visceral disease, and prior treatment with checkpoint inhibition. Now, as I mentioned before, there is a lot of activity in this field, and despite the accelerated approval that happened in the platinum refractory disease setting, there is ongoing effort to further evaluate the role of FGFR inhibitors even in the frontline setting. So Dr. Pauls presents some very interesting data from the phase 2 NORSE trial at ESMO 2021, about 3 months ago. These are patients in the frontline setting, not fit for cisplatin, and they were selected based on the mutation or fusion of FGFR2 and 3. They have measurable disease, and again, first line, no prior therapy for advanced disease. And they got randomized to erdafitinib, 8 milligrams once a day, or the combination of erdafitinib plus sertralimab and checkpoint inhibitor, and that's interesting to see whether the combination may give some additive or synergistic effects. Primary endpoint was overall survival, it was overall response rate and safety, and key secondary endpoints was disease control rate, duration of response. Survival was looked up as an exploratory endpoint, but the primary endpoint was response rate. As you see, this is a small sample size, only 37 patients, 18 on erda alone, 19 on erdafitinib plus sertralimab, so keep that with a grain of salt because of small sample size here. But the response rate is double. It's 68% with a combination of erdafitinib plus sertralimab and 33% with erdafitinib. This is frontline setting, cisplatin-ineligible patients, so definitely a promising signal despite the small sample size with the anti-FGFR and the checkpoint inhibition. The median duration of response was about 7 months with a combination, and the disease control rate was very high. You see 90 to 100% in both groups. So definitely interesting data. Again, small sample size, we need longer follow-up and larger sample size, but the combination looks very promising. And this reminds me some other data from Dr. Rosenberg, looking at another FGFR inhibitor, regorafenib plus atezolizumab, that also showed some very interesting data in platinum refractory disease. So I think it's interesting to follow along and see whether this combination of inhibiting FGFR and checkpoint inhibition, whether we'll have future. For the present, though, it remains experimental only in clinical trials. And speaking about clinical trials, the accelerated approval of erdafitinib was the first step, but there is a confirmatory trial to see whether this will be regular approval or not. And this takes patients who have metastatic disease, and they have screening for FGFR 2 or 3 mutation or fusion, and they get randomized. There are 2 randomizations. One is the erdafitinib versus chemotherapy, vinflin or docetaxel. These are patients who had prior immunotherapy, as you see, in no more than 2 prior lines of therapy. And the second randomization is erdafitinib versus pembro, and that's an interesting comparison there for patients with platinum refractory disease to find what is the best second-line option for those patients. So you go for erdafitinib or checkpoint inhibition in the platinum refractory second-line setting. We don't have any data yet, but we're looking forward to the results of that trial. Extra attention, toxicity profile of all these agents. Erdafitinib has some unique features we have to keep in mind. It's important to maintain optimal oral hygiene. Mucositis, stomatitis can be a frequent adverse event of erdafitinib. Very important to monitor for skin and nail toxicities, referring to dermatology and podiatry if needed. Early on, I think we have a dermatologist in our cancer center, and I can tell you we frequently discuss with them and refer patients both for antibody drug conjugates and erdafitinib. And of course, very important to have best supportive care and close monitoring and educate the patient to avoid underreporting. It's very common for those patients to underreport because they want to stay on treatment. And so we have to educate them to make sure they call us right away. And advanced practice providers, nurses, physicians all have a role in this mission. Hyperphosphatemia is a class effect. So we have patients who develop high phosphorus level on FGFR receptor inhibitors. We recently published some data with infigratinib, another FGFR receptor inhibitor with Dr. Pal and Dr. Liu, and we showed that the higher the phosphorus level, higher chance of response, but you still have to manage the hyperphosphatemia, right? It's like hypertension and axitinib. In kidney cancer, you have to manage the blood pressure. So this is a pharmacodynamic effect because you inhibit the FGF receptor in kidney, and you may affect the reabsorption of phosphorus. So we have to educate the patients, send them to nutritionists, dietitians if possible, and have them follow a low phosphorus diet. And if need be, depending on the level of phosphorus, you may need to give a non-calcium containing phosphate binder like sevelamer or something else. So keep a close eye, and you have to do blood work 2 weeks or 3 weeks after you start this agent in order to see the phosphorus level for 2 reasons. Number one is toxicity management, right? To manage the hyperphosphatemia. The other one is because you may actually tweak the dose. You have a check of labs, and if you have no grade 2 or higher toxicity, and you have no visual eye toxicity, at 2 or 3 weeks and your phosphorus is below 5.5, you can increase the dose from 8 milligrams to 9 milligrams. Sounds a small increase, but actually have shown in the BLC 2001 trial to have impact on response rate. So there's a dose titration that you can do based on toxicity and also based on the phosphorus level. Which brings the point that ocular toxicity is a very important point here. Patients should see an ophthalmologist at baseline before they started dafitinib to look at the cornea, the retina, do an optical CT, and look with dilated eye exam because you want to make sure there's no underlying corneal retina pathology. And I send these patients to ophthalmology at baseline, and I ask them to be seen monthly for the first 4 months, and then every 3 months thereafter, unless they need to be seen more frequently if there is any challenge or any toxicity. I also give them an Amsler grid, which is a grid with a black dot in the middle, and they put it in their kitchen every morning. They look at them and they screen for blurry vision, which I think is very important to do that for education of patients and screening for blurry vision. Blurry vision is, even if it happens, it usually goes away if you stop the drug. So it's exceedingly rare to have any real permanent issue there, but it's important to catch it early on if it happens. So Amsler grid and ophthalmology are important. And the central serous retinopathy happens in about a quarter of those patients, usually grade 1, grade 2, but it's important to follow the package insert and hold offer dafitinib. And if you have no resolution within a month, you may need to stop the drug. And of course, you have grade 4, you have to stop it permanently. But this collaboration, right, with especially ophthalmologists in that case, which may be hard to find, to be honest, in some community practices, is a key in managing this toxicity. I think but it's important to, also to keep the patients on treatment if they do well, if they have no toxicity. So I'm going to move forward here. We talk about dafitinib and the accelerated approval. It's an option for our patients who use it in clinical practice, but we also use antibody-drug conjugates, and 2 of them have approval in metastatic urothelial cancer. Enfortumab vedotin has a regular approval based on phase 3 trial data with level 1 evidence in patients with platinum-refractory and immunotherapy-refractory disease. And this is an anti-Nectin-4 antibody-drug conjugate, targets Nectin-4, has a very potent linker, which is protease cleavable, linked to the MMAE, which is a microtubule inhibitor, and this is releasing, this payload, this chemotherapy drug, into the cancer cells that express the target Nectin-4. Sacituzumab govitecan, we heard earlier today from Dr. Tagawa, is a different antibody-drug conjugate, has accelerated approval in patients with platinum-refractory immunotherapy-refractory disease, and the target here is different. It's TROP2, which also expressed in the membrane of urothelial cancer cells, had the hydrolyzable linker, and the payload is different. It's NSN38 with the active metabolite of irinotecan, a topoisomerase 1 inhibitor. So different toxicity profiles between the 2 drugs based on the mechanism of action. So this is the phase 3 EV301 trial. I want to make the point here that there was a phase 2 trial called EV201 that actually had 2 cohorts, cohort 1 and cohort 2. Cohort 1 led to the accelerated approval of enfortumab vedotin in the third-line space, and cohort 2 led to a recent FDA approval of the second-line space for patients who had prior therapy and they're not fit for cisplatin. So EV201 was 2 cohorts, phase 2 trial, and we have 2 approvals based on that trial. And the phase 3 was the EV301, the confirmatory trial. Enfortumab vedotin, this antibody-drug conjugate against Nectin-4, was compared to taxane single agent or vinflunine in Europe. And the primary endpoint was overall survival. Of course, PFS and response rate and safety were also looked at. The trial was positive, again, third line and beyond. Enfortumab vedotin was superior compared to taxane or vinflunine in the third and beyond line space. Overall survival benefit with hazard ratio 0.70. There was also significant PFS benefit, hazard ratio 0.62, and significant difference in response rate, more than double response rate with enfortumab vedotin compared to taxane or vinflunine. And there were no new safety signals in that phase 3 trial compared to the phase 2 trial. Of course, we have to think about the adverse events of all the agents, specifically with enfortumab, skin reactions, skin rash. There is an FDA black box about a rare, not common, but can happen as Stevens-Johnson syndrome. We have to keep an eye on skin toxicity. It's usually mild to moderate. Peripheral neuropathy, hyperglycemia that could be life-threatening. It's rare, about 5% of patients, but keep an eye on the glucose, of course, and some other side effects that are published, like fatigue and anorexia. But overall, I think this agent has an established role with level 1 evidence in the third-line space. And as I mentioned, it has also an approval by the FDA in the second-line space in patients who are not fit for cisplatin and they had prior therapy, so second-line or third-line. So keep an eye, I think it's an important tool for our patients, and we see significant symptomatic benefit as well, palliative benefit with this agent early on. Another important antibody-drug conjugate, as I mentioned, is sacituzumab govitecan. Dr. Tagao did a great job earlier today discussing the data from cohort 1. Cohort 1 was patients with prior platinum-based chemotherapy and checkpoint inhibition, and the third line or beyond. Many of them had multiple prior therapies. Cohort 2, we have some early data from Dr. Petrolak, is still ongoing. It's the second line sacituzumab govitecan in patients with prior checkpoint inhibition. Cohort 2 is still ongoing. Cohort 3 are patients who had platinum-based chemotherapy first line, and the second line they got Pembrolizumab plus sacituzumab. So a combination Pembro plus sacituzumab, this is cohort 3. We don't have any data yet. Cohort 4 is cisplatin plus sacituzumab in the frontline setting, and we also have cohort 5 looking also at maintenance, sacituzumab plus avelumab. So we have a lot of data coming up from this trial. The overall response rate, we published this paper with Dr. Tagawa and JCO a few months ago, and that led to accelerated approval of this agent in the third line and beyond space. And you see that the response rate was 27% in a heavily pretreated population with multiple prior therapies, and about 3/4 of the patients had reduction in the tumor size, and we have seen responses across different locations of metastasis. As you see in the swimmers plot, some responses may be durable. Median duration of response was more than 7 months, median PFS 5.4, median OS 11 months. Obviously, this is a single-arm phase 2 study, so we have to take the PFS and OS with a grain of salt. The toxicity profile is a little bit different. In neutropenia, there was about 10% febrile neutropenia in the study that is usually managed with growth factor or with dose reduction. Anemia, about 14%, and diarrhea can happen. About 10% of patients had grade 3 diarrhea, with something to keep in mind. And it reminds you of toxicity of irinotecan, right, for those who have treated GI malignancies. So the accelerated approval by the FDA is now followed by a phase 3 trial called TROPiCS-04. We presented this trial before in a previous meeting as a trial in progress. This is similar to the EV-301 trial that led to the regular approval in form of vedotin. So this trial is sacituzumab govitecan single agent on the FDA-approved dose, 10 milligrams per kilogram, days 1 and 8 on a 21-day cycle, versus taxane or viflin, the primary endpoint of overall survival. This is patients in the third line and beyond. So these patients may have received enfortumab vedotin based on physician discretion. As I mentioned, we're going to look at overall survival as well as a plethora of other endpoints. So antibody-drug conjugates are being tested in different disease settings. We have EV-103, Pembro plus EV, very promising data, 93% disease control rate, frontline settings, cisplatin-eligible patients. We have randomized cohort data coming up in the future from EV-103 and the EV-302, which is pembrolizumab plus EV versus chemotherapy. And recently we heard that maintenance avelumab is allowed in the chemotherapy control group. Earlier in the muscle-invasive disease space, pembrolizumab plus enfortumab vedotin, followed by stectomy and then adjuvant therapy, interesting trial to look at. And we discussed about the neoadjuvant option to test the antibody-drug conjugate. So we have sacituzumab govitecan plus minus pembrolizumab as a neoadjuvant therapy before radical stectomy in patients who are cisplatin ineligible. And we have also a combination of ipi/nivo plus sacituzumab being tested in frontline setting metastatic disease for cisplatin ineligible patients. So as I mentioned before, different toxicity profiles from different agents. Keep an eye, of course, in the bucket insert. Peripheral neuropathy usually is something improves when you hold the drug, but be very, very careful. I personally have a low threshold to dose reduce if I see neuropathy with enfortumab vedotin. Keep a close on hyperglycemia. About 5% of patients get hyperglycemia, can be potentially life-threatening, so keep an eye on that. And skin rash, usually mild to moderate, but rarely you can have Stevens-Johnson, so keep an eye on it to optimize the management of the patient. Sacituzumab govitecan, bone marrow suppression, usually managed with dose reductions to hold, and/or growth factor support, and diarrhea, education, hydration, diarrhea medications. You have to rule out infection sometimes. So we'll go quickly here in this patient, a 68-year-old lady with metastatic disease, got frontline Gemcitabine for 6 cycles, had partial response, and has some new neuropathy symptoms because of cisplatin probably. Went on with switch maintenance avelumab. As Dr. Gupta mentioned, this has level 1 evidence, and had symptomatic progression about a year later with back pain. Imaging showed some bone mets and also liver metastasis. NGS of the bladder tumor tissue showed an activating mutation in FGFR3. So the patient has no eye, skin, or nail, or GI issues, and is diabetic with a hemoglobin A1C 9%. Dr. Gupta, what would you do?
Yes, Petro. So this patient had good response to chemo, but had neuropathy as a complication, and switch maintenance avelumab progressed through it. Given that the patient has FGFR3 mutation, erdafitinib is a very reasonable choice in this case, and so is sacituzumab govitecan. You know, at some point, patient will need sequencing with both those therapies. We just don't know which sequence is better, but one could start with erdafitinib.
Dr. Steinberg, any comments?
I suspect that ultimately the patient will see enfortumab vedotin, and potentially, if that's not effective, sacituzumab govitecan. But I suspect that ultimately they will be placed on enfortumab vedotin.
Gotcha. And with the activating mutation of FGFR3, would you think that people would favor the target therapy first, especially in the context of neuropathy and high hemoglobin A1C, or you think that you can still go for enfortumab?
The thing that I've seen, which is truly amazing, is kind of rapid response to EV in patients with liver and bone mets that I don't think you see as much with erdafitinib.
Interesting, and as you both said, we don't know the optimal sequence of those patients. Especially with a mutation, right? We have level 1 evidence with enfortumab in all comers, but the optimal sequence in those with the activating FGFR3 mutation is still to be defined. In those, erdafitinib can be an option, enfortumab can be an option, sacituzumab can be an option. So this is the same scenario, but in this case, you don't have FGFR2 or 3 mutation. So in this second case, erdafitinib is out. And then it probably comes down to enfortumab versus sacituzumab. Any comments on how would you?
I would say that enfortumab, no doubt, is very effective, but given the neuropathy, we might want to use sacituzumab first, and when neuropathy gets better, use enfortumab. Like Dr. Steinberg said, this patient is most likely going to see all different therapies in her journey.
Great discussion, and that's why we need, more real-world data to see what happens in real practice, right? And how many patients can be captured, and receive all these important therapies. It's great to see the data from all these trials really panning out. Let's see what we have next year. I have some key takeaways, and I have a couple of questions for you to learn from you, Dr. Gupta and Dr. Steinberg, before we leave. So immune checkpoint inhibition with FDA-approved agents across therapy settings has had a significant impact in the management of patients with bladder cancer. In BCG-responsive CIS, we have about a 20% ballpark durable clinical complete response rate with pembrolizumab based on the Keynote 057 trial that led to the FDA approval of this agent in this disease. And we have a similar result from the SOC 1605, but at the resolution is not FDA approved in that setting. And data from the nadofaragene firadenovec and the oportuzumab Bonadox, it's probably in the ballpark. So we'll see what happens with those agents. In muscle-invasive disease, significant disease survival benefit with adjuvant nivolumab is FDA approved now, regardless of PD-1 status or receipt of neoadjuvant spell-based chemotherapy. And this is based on the CheckMate 274 trial that we presented a few minutes ago. In metastatic disease, platinum-based chemotherapy is probably the treatment for most patients up front, and switch maintenance avelumab is standard of care, regardless of if they go Gemcis or Gemcarbo. And in my bias, regardless of CR, PR, or stable disease, I think all these patients benefit with significant benefit, but with different degree of benefit based on response to stable disease. And atezolizumab, pembrolizumab has a role in the frontline setting, as Dr. Gupta mentioned, mostly in patients with platinum-ineligible scenarios when you cannot give cis or carbo. Atezolizumab has the option to be given in cisplatin-unfit PD-L1 high patients based on the Ventana SPN42 assay. FDA-approved non-immunotherapy agents include erdafitinib, FGFR inhibitor, and enfortumab vedotin, again, level 1 evidence based on the EV301 trial, and sacituzumab govitecan accelerated approval based on the TROPHY U01 cohort 1 trial. And there are important options for those patients with pretreated disease. Each agent has unique adverse event profiles, FDA-label indications, and management strategies. And all members of the healthcare team are very important to be familiar with this mechanism of action, the range and the different types of adverse events, to allow prompt timely recognition, education of the patient, and optimal management of the adverse events, which I think is very important. So very quickly, we have a couple of minutes, maybe a few seconds left. First question here. With TROP2 being expressed in muscle-invasive disease, Is sacituzumab being studied in muscle-invasive disease? The answer is yes. There are some neoadjuvant trials going on that's very interesting, looking at antibody-drug conjugate sacituzumab plus checkpoint inhibition or as single agent, so we'll have to see how the studies pan out in the future. It's a good question, and for the moment, we have not seen data yet from sacituzumab in the neoadjuvant setting, but we're waiting those trials. And the same thing with enfortumab. There are now phase 3 trials with enfortumab in the neoadjuvant adjuvant setting. How can urology and oncology clinics work together to better serve our patients? Any words of wisdom? Dr. Steinberg first.
That's always the $64,000 question. I think that certainly in the academic setting, it's very common for the medical oncologist and the urologist to work as one team and to have multidisciplinary clinics or to refer back and forth. In the real world for urology, I really do believe that there's going to be a time in the not too distant future where urologists are giving their own checkpoint inhibitors. Pfizer has Sesalimab, which is a subcutaneously delivered PD-1 inhibitor. I think that urologists will gravitate to that rapidly because of the ease of administration. Having said that, the IRAEs with the sub-Q administration are going to be no different than the intravenous, and we certainly need to see the efficacy from the CREST trial. But I think that urologists are going to be getting more and more involved with checkpoint inhibitors. I think it's going to be critically important for medical oncologists to educate the urologic community. One thing that is very, very clear to me is that urologists still have a tremendous role in the management of bladder cancer. We understand the anatomy, we understand the functionality, we just have a much better grasp of what it is. All too often in medical school, and I think for a lot of non-urologists, the bladder is just this black box that has, some nerves and tubes, and nobody really knows how it works. And so I think that's why urologists are going to be critically important. And the medical oncologists have done all of the heavy lifting, so we know what the IRAEs should be. And it'll require working together to make sure that we monitor the patients effectively.
Thank you, Dr. Steinberg. Great question. Silpa, Dr. Gupta, very quickly in 10 seconds, platinum refractory disease, you are between, let's say, you have enfortumab, you have erdafitinib, you have pembro, second line in an FGFR2 or 3 mutated patient. Who do you use second line?
That's also a $1 million question, Petros. All those are reasonable options. Given pembrolizumab has level 1 evidence in prior platinum, I would use that first, reserve FGFR inhibitor for later, and enfortumab would be a reasonable option too. Having said that, a sequencing trial really needs to happen before we can say for sure.
I like the answers of clinical trials, and all these options are great. And thanks everybody for your time.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/RPD860. This activity is supported through educational grants from Bristol Myers Squibb, Gilead Sciences Incorporated, Janssen Biotech Incorporated, administered by Janssen Scientific Affairs LLC, and Merck & Company Incorporated. This activity is certified by Medical Learning Institute Incorporated. This activity is developed with our educational partner, PVI, Peerview Institute for Medical Education.